We have, for the third time, Dr. Amanda Legge. And I hesitate to pronounce the name of the practice. Missing?
You got it.
I got it.
Center.
There we
go.
Got it. In Pennsylvania. Yeah. Mm-hmm. Today, we're talking about dry AMD. And of course, I guess the easiest or the first question to ask is, what is dry AMD?
So I found this as I think the simplistic and best way that makes sense for all of the conversation that is to come. So macular degeneration, just as a whole, as a disease process, is a breakdown of the transport between the healthy retina, where we see, and the blood vessels that are underneath that. And there's a natural membrane that's there that's important to help act like a sieve and get waste out and then nutrients in. So at the heart of all of this, macular degeneration is a fault in that transport process. So how that happens is the disease builds up this tiny, invisible right now, cholesterol wash inside of that membrane that's between the retina and the blood vessels underneath. And as that wash gets thicker and thicker, eventually we can actually visualize, and the eye doctors can visualize it as Drusen. But Drusen in true macular degeneration really are only the tip of the iceberg that we can see. And what Drusen are made out of are all of these waste products that our retina makes. So just like every other cell in our body, it takes in light, it does its job, it helps us see, and it also produces waste. Typically, that waste from the retina gets pushed underneath that barrier into the bloodstream and gets passed along with the rest of the waste in our body. And so as that waste product builds up and that membrane gets thicker and thicker, the bigger issue is not really the waste getting stuck. The bigger issue is the nutrients underneath are not getting in, both because of that dysfunction of the transport process, and as drusen get thicker and more of them, it's just another barrier to get to the retina. So all the things that you hear about how to slow the progression of AMD, how to prevent AMD with regards to, exercise and not smoking and healthy diet and controlling things that gunk up your blood vessels like diabetes and cholesterol and high blood pressure, all of those sort of fall in line and then make sense because all of them are trying to improve the vasculature underneath the retina and increase with good nutrients in your bloodstream from a healthy diet and more exercise, which kind of pumps more oxygen and your blood flow through and will push more nutrients through. All these things are just trying to nourish the retina more where they're lacking. And hopefully, by doing that early and diagnosing it in the early intermediate stages, we can slow that progression down enough that hopefully people don't have vision loss from it. But of course, for those who do progress and continue to get worse, then our job turns from diagnosing and managing and preventing vision loss. It goes to making sure that if you convert to wet AMD, which is about 15% of the time, that we want to catch that absolutely as early as possible. And I can talk about, there's several studies that have shown whatever your visual acuity is at the time you're diagnosed with wet AMD and you start treatment, that's about what your vision is 2 years later after you start treatment. Which means if you have like pretty good vision, 20/40, 20/30 or better, in 2 years, you still maintain that. If you have a lot of vision loss before the wet is diagnosed and treated, it might get marginally better, but you never improve from like the 2200 line back to 2025, 2030. It almost never happens. So diagnosing it early to hopefully prevent anything, and then watching really carefully for any conversion to wet as early as possible is really the name of my game in order to help people's vision in the long term and managing the disease as a whole.
All right. And I know that your specialty is diagnosing AMD even before it can be seen in the eye. Do you want to talk about that?
Yeah, so we do that with an instrument that tests dark adaptation. So what dark adaptation is how long it takes your eyes to adapt from the bright to the dark. So sort of like walking from a really bright sunny day and going into a movie theater. And, it takes like that delay until you can see and get to the ticket counter and that sort of stuff. There's a couple of seconds to minutes delay, normal for everybody. But going back to at the heart of macular degeneration with this waste deposition and that things are not going through this barrier, one of the biggest molecules that has to push from the blood vessels underneath into the retina is vitamin A. So vitamin A is super important for our eyes, specifically with this adaptation from light to dark. That's why here carrots are really good for your eyes. Interestingly, just an interesting fact, dark adaptation has been around for a long time, and we've known that it is related to vitamin A deficiency. Back in like World War I, where things in Europe were just decimated, their crops, etc., they couldn't synthesize vitamin A like we can today. So there was a shortage of it, but people weren't getting enough vitamin A. So they decided to figure out who was the most vitamin A deficient by checking dark adaptation. And those people got vitamin A that was so hard to make back then. And then others, they just sort of watched. So interesting. It's been around a long time. It's not a new concept. But sort of what's new about it is that we've discovered that macular degeneration is sort of like a localized central vitamin A deficiency. So where that vitamin A can't get through that barrier, it takes longer and longer for your eyes to adapt from the bright to the dark. So the way that the test that I use works is it does this bright flash in the beginning. It's sort of like a flash from a cell phone camera, not super bright, but it's bright enough. And then you're shown dimmer and dimmer lights over a period of time until we get to the dimmest light at the very end. So everyone takes the same test as in this, the bright flash is the same. We're just waiting to see how long it takes you to see the dim flash at the end. So the normal cutoff for that, for the instrument I use, should be less than 6.5 minutes. Most people who do not have macular degeneration do that test somewhere between like 3 and 5.5 to 6 minutes. But as you have even early macular degeneration, so even before I can see signs of the drusen in your retina, the dark adaptation gets a lot longer because things are happening to the rods and the cones of the retina cells that we just can't see yet. Even with the OCTs and imaging and all the tests I'm sure everybody has had, we just don't have the technology to visualize it yet. The way we know that exists is because there's been studies with donor eyes, cadaver eyes that have, some had macular degeneration, some didn't, and they took samples of their retina tissue and they were able to see with electron biomicroscopy that that layer is there. But my patients aren't in good spirits for me to take out their eyeballs and dissect their retina to find out. So we sort of infer that that's going on by this delayed dark adaptation. And it's not seconds of delay, it is minutes of delay. So typically my patients with like early macular degeneration probably takes them on average like 10 to 12 minutes to complete that test, where again, normal is less than 6.5. Patients with intermediate and like progressive intermediate takes them up to 20 minutes to do it. That's about where I cut off because it's just tortuous after that 20-minute mark. But with the studies with late macular degeneration, it takes those patients 45 minutes to complete the test that somebody without macular degeneration does in less than 6.5. So it's not seconds of delay, it's a long period of delay. So it helps us catch it even before we can see anything in it. And it helps me for patients that do have macular degeneration to follow them in a way more than just looking at their structure. So what we know is you can have drusen, and there's certain risk factors and we can talk about that makes it more likely for you to convert to wet macular degeneration, but all of this until dark adaptation is just based on anatomy. So it's us watching, size, shape of drusen, if there's pigmentary changes, if things are progressing over time. But most other eye diseases that we manage, like glaucoma is a good example, we always check structure, anatomy with things, and we check something with function. So in glaucoma, it's looking at the optic nerve, and we take these side vision tests because that checks your peripheral vision. So now with the dark adaptation, it helps me a lot because I get information about the structure like we always do with the OCT and photos and imaging, but put that together with the functional component of it. And I've been doing this since 2013, and it's interesting now having that longevity with it, because I've seen some people progress functionally a lot faster with regards to the dark adaptation, and they convert to wet macular degeneration where the retina doesn't look too bad. And I've seen other people whose retinas look sort of like trash, just terrible with drusen all over the place. And their dark adaptation sort of holds on for a long time and they do okay. And they are honestly, and in my experience, just less likely to progress to wet macular degeneration. So it helps balance some things, just gives another piece to the puzzle and information about the full picture. That way we can figure out what's happening, how fast you're progressing, how fast I should see you in my office, talking about, which we can talk about, the at-home vision monitoring device that can catch early wet macular degeneration better than Amsler grid testing. And it just changes the way that we talk about it, do follow-ups. And because of how I've been doing that, in the last 3 years, I'm now up to 13 patients that I am just seeing on their regular monitoring schedule based on how I feel at risk they are to convert to wet. But they've come in for their regular appointment with me, no symptoms, no changes to their Amsler grid. Their vision was 20/25, and they converted to wet that I found. And their vision, like 2 years later, is still like 20/30, 20/25. It's like unbelievable. So the longer I do it and I'm in it, like the more impressed I am that the system actually works, and we can just add that to our gamut of testing and give us more information.
So you're not, okay, for somebody who has no symptoms or, well, no symptoms of AMD, the dark adaptation test can give you a clue that they have it beginning, but you're also saying, or are you also saying that it can give you a clue as to their progression?
Correct. Yep. So when you're in dry, I have some people that are, they start out at, it takes them about 8 minutes to complete that test. And then as I watch them over months to years, that 8 minutes might jump to 10 minutes. And then it might jump to 13 minutes and, et cetera. And you can see this elongation that it's taking them longer and longer to do the same test, because presumably that cholesterol buildup's getting worse, less nutrients are getting in. And that's just a red bell to me. Like, I better watch this person real close, because I'm concerned that they're fluctuating, changing enough that they could be one that converts to wet, that we want to make sure we're right on top of in case that happens.
I know that, well, I would bet that there aren't a lot of people in the group with dry AMD who have had this test.
Yeah, so it is true. So it's newer. It launched to market for purchase in 2013. We were one of the first practices in the country to own it. It's definitely picking up traction that most all optometrists are aware of dark adaptation and how it relates to macular degeneration. So the company that I work with is called Maculogics. They've done so much in the way of educating patients and doctors why it's so important and getting the word out there about it, because I graduated 10 years ago and I was not taught dark adaptation. This is like newer information. So anyone, 9, 8 years and before has no concept of it from our schooling anyway. So it's something really to learn to sort of wrap your mind around, because it's a different way to approach macular degeneration than we were taught in school. So I think it's a little bit slow to start, but there's also a lot of optometrists across the country that do utilize it. And I can give you, the link or so, but on Maculogics' webpage, if you type in your zip code, it'll tell you who has it, within your area.
I have shared that link before, but I will do that again when I post the video tomorrow. So yep. That's certainly good to know. Before we talk about converting to wet, when we discuss slowing the progression, of course, the subject of AREDS and AREDS 2 comes up. Mm-hmm. And we've had this discussion before, and it's one where there is very, very little agreement as to who's a good candidate for it, despite the fact that, the study's pretty clear in who they tested. Why is there such a lack of agreement as to who should take it and who should not? Should they take 80 milligrams of zinc, or should they take less? What do you advise your patients?
Well, so we'll go back to some of the controversy with it, right? So the AREDS was now done twice. So it was a huge study with thousands of patients that was sponsored by the National Institute of Health and the National Eye Institute. So it wasn't a pharmaceutical company. It was our government and our actual health organizations. And so in AREDS 1, what they found was a certain formulation of vitamins, which at that time included ACE, 80 milligrams of zinc, and then typically beta carotene was in it, which is sort of a different carotenoid. It's similar to lutein and zeaxanthin, but the problem with beta carotene is that we discovered people who were smokers had an increased risk, a significantly increased risk of developing lung cancer if they took too much beta carotene. So for a while, if you've been on these vitamins for a while, like back 8-10 years ago, there was then AREDS for non-smokers and there was AREDS for smokers, and it was super confusing. And the smokers version had lutein in it, but lutein really wasn't studied in AREDS 1. So it was a substitute because it's similar to beta carotene, but we didn't even really know if it did the same thing for smokers. But we can't go around giving people lung cancer either. So AREDS 2 came about, and this is where most of the controversy comes from. So AREDS 2 came about, and it was, everybody knew it was in the works. Like, we knew the day that the study was going to drop their results, and waited with bated breath. And it was sort of anticlimactic at first, in that they tried to see if omega-3s had anything to do with it, and they found that it made no difference to add like omegas, fish oils to the supplements. They studied that zinc, and they showed that lessening the amount of zinc to 40 milligrams didn't make it better or worse. It was just sort of the same. But some people think that because the original study was at 80 milligrams, it was definitely determined in AREDS 2 that the 80 milligrams still works. That there are some people that just really stick hard with the 80 milligrams of zinc, and they recommend it because those two studies like are in agreement with each other, is the general concept on that side of it. The other side of it is that, and I'm sort of in this camp, is that I feel like the less medication or supplements, whatever I give you in your body, the better. That zinc can cause some stomach upset and, you know, some other things over time, where if the 40 milligram was proven in AREDS 2 to do the same thing, like, why would we recommend the 80 milligrams? So that's
wait. Let me stop you. Do you mean 40 milligrams or do you mean 25 milligrams?
I'm sorry, 25, the 25.
Okay.
The less one. 40 was also in there, but 25 was still the same as the 80, the results. So
40 milligrams of zinc, according to the, I guess it's the FDA, is the upper safe limit of zinc.
Yeah,
maybe.
And so, yes, maybe that is. And the 25, then they lower it because most people in AREDS 1 and AREDS 2 also were on a multivitamin at the same time. So when I recommend AREDS, it's in addition to a multivitamin. Mm-hmm. In the studies, it was mostly Centrum Silver that patients took, just as an aside with that. Mm-hmm. So that's like sort of where the zinc versus like the higher zinc and the lesser zinc comes into play. Now you can go into another category talking about no zinc, right? Where there's after people have studied the study, right? So this happens sometimes, but the public doesn't understand it. So the study results initially came out sort of anticlimactic. People were sort of debating it. But then over time, once all of that data is released, then everybody's digging deep into the data and finding if there's any trends happening that just hasn't been analyzed yet. So during one of those studies and assessments, they showed that a small percentage of patients who had a specific genetic defect actually did worse taking zinc on AREDS than not taking it at all. So that's only like one study, and it's sort of like an analysis of an analysis. So the split on that becomes, it's the American Academy of Ophthalmology has taken the camp of it doesn't make a difference for our clinical decision making. It's too expensive to make that worthwhile for people to go through. So the American Academy of Ophthalmology stance is that they do not recommend genetic testing, and it just goes by AREDS 1, AREDS 2. You know, there's some ophthalmologists and also some optometrists in the camp of, well, this potentially is going to make my patient worse. I want to know who's going to get worse on it, who doesn't. So we talk about genetic testing, and if you have one of the defects in a specific gene, you're recommended to not take zinc at all. And there's still a lot of controversy just over the specifics of that study and how much you believe it is absolutely accurate just by analyzing the data versus its own individual study. So there are some definite doubters. The American Academy of Optometry and the American Optometric Association haven't really like taken it up as it. So some doctors on their own do, some don't, and there's some controversy between that. So that's the 80 milligrams, 25 milligrams, 0 milligrams controversy that's over it. I think that's the biggest of like what's in the supplements controversy. But then the other step is like, who should take AREDS? All right. So per AREDS 1, they studied at that point early and intermediate patients and had some people on the AREDS formula and some people on nothing, like a placebo. And they showed that those that had intermediate macular degeneration had less of a chance to progress to wet compared to those in intermediate AMD that didn't take it. So that was shown, but what wasn't shown that was that early macular degeneration didn't really have a statistically significant difference. But some of the, which means that we're technically by AREDS 1 recommendations, it really is for intermediate AMD and late in one eye or intermediate in the other. Like that's really what it was approved for. But then the thought comes in that you can have early macular degeneration and be in that early stage for a decade or more, 2 decades, and maybe never change. So, you know, the question and sort of the controversy around that is, well, did we just not study the early patients long enough to find out if it does make a difference or not? Because maybe it does, but it's way down the road that we're just not getting these exciting results within a couple of years in a study. You know, so then you're just weighing, everything is weighing risk versus benefit of whatever we're talking about in medicine, right? So if you're, I think it's reasonable if you have early AMD, and the way I do it with my patients is to have a conversation, a very real open conversation with them that like, hey, it's really been proven and the science is telling us that it's for intermediate and later. However, like reviewing your medications and what your medical history is, there's really little downside of you taking the AREDS formula. So, you know, if you have, you know, unhealthy diet that you're not likely to change because of like work schedules, kids, like whatever's going on in your life, maybe that's more appropriate for you. You know, if you're somebody who has, you know, uncontrolled diabetes, high blood pressure, anything that way, maybe it's more right for you. So there's not a right answer with early macular degeneration. There really isn't. I end up having a conversation with all of my patients in that stage, and we sort of make a decision together about what's best for them at that moment in time.
It is true that people with AMD need nutrients in addition to what's in the AREDS formulation, right? I mean,
right.
So is that where diet would come in, especially, would you say?
Yeah, diet's very important. And so is, you know, just the multivitamin effect too, because the other argument we'll say with the AREDS 1 and 2 studies is that the majority of patients in those had very good nourishment and sort of had healthy diets already. So we know most Americans especially don't really live up to that good nutrition status. It's just unfortunately like part of our poor diet habits here. So then the question is like, well, maybe you're not getting enough in certain populations, but some better than others. And when again, another sort of analysis after AREDS 2 came out, it did show that there was a statistically significant difference if people had very low concentrations of lutein, that they did benefit early on to take AREDS. Whereas if you had good nutrition, you had high levels or higher levels of lutein in your bloodstream, it really didn't make much of a difference. So we kind of go by I go by a couple of different factors of whether or not it's right for you and their comfort level. Some patients want to be more proactive. Some want to sit back and just see if it changes. You know, we can always change our mind and do nutraceuticals down the road if we have to. So I think it's a conversation to have back and forth with your doctor. They'll give you recommendations, and every doctor, no matter what their belief is around AREDS, et cetera, like they've chosen a camp and they've done so in good faith that they really believe what they believe based on the studies. There's just a lot of controversy with it. And until something is really solidified, unless you have intermediate AMD, which has shown that, you know, you should be on nutraceuticals, everything else, there's just not a right answer yet because we just don't know, is what it comes down to.
And nutraceutical, could you define that?
The same as vitamins. I'm sorry.
Yeah.
So like just a non-regulated.
Yeah. A
supplement.
Nutra, not pharmaceutical.
Not a pharmaceutical and nutraceutical.
Gotcha.
Which also is tricky then, right? Because then you get into things like nutraceuticals are not regulated by the FDA.
Yeah.
This is like a nightmare for me. This is the worst part of my conversation about the supplements with patients is that, like, I want you to be on, and I'm not going to say a specific brand, but I want you to be on this because I know it's been studied separately. I know it's definitely in it. And I know it's what I'm recommending for you. So I'm sure you've discovered you go into, you know, your pharmacy or Target, whatever, and you go to the vitamin section. There's just like a sea of eye vitamins. Like there's just a whole like rows and sections for eye vitamins. And a lot of them say retina health, the macular health, etc. But if you actually read through all of them, they don't at all follow the AREDS formula. So it's super tricky that I always just say, like, ask your doctor for a specific recommendation. Like, please don't tell me just to get AREDS 2 because they're not all the same since nobody's really checking all of that as it goes to market.
Yeah. And once again, we all wish we had a doctor like you because you've been in the group long enough to know that a lot of our members don't have these conversations, not because they don't want them, they're just the doctor does not initiate them. And some doctors aren't as open to questions. And, you know, nothing we can do about that, is there?
No, I mean, there's good, bad, and ugly in every profession, right? And some is by design with how practices are set up and just how busy some people are. Some, it really is just a poor personality, but that is across the board in any profession, which makes me really sad in this case because it's the patients that suffer. Like, it's not us, it's the patients.
Oh yeah.
Drives me bananas.
Yeah.
Because as I'm talking to other, you know, optometrists around the country, like my begging of them is like, please just educate patients. Like, if you do nothing else, recommend nutraceuticals, nothing else, like, please educate your patients. Like, say the words, they have macular degeneration, explain what it is, and give them some idea, because there's some optometrists, it's just interesting. They're so afraid of saying somebody has macular degeneration, and that patient gets really scared, which is absolutely their right to do so. It's a scary diagnosis. But then they'll go down the street to their retina specialist to have a double check. And the retina specialist is like, oh, you're fine, like everything is good. And now that optometrist has just like lost a patient. Yeah. And by that, with the retina specialists, I mean, especially with early AMD, because they're so inundated with the wet and the injections that most retina specialists don't have a ton of time for those with early, especially macular degeneration. So optometrists are hesitant because of that. The retina specialists are inundated with wet AMD. So I feel like there's just this open hole for patients with early AMD. Everyone takes intermediate seriously. But the early is just sort of forgotten in a way. So optometrists are scared to say anything. And then it's the patients that lose out, because it's not going to be that one patient that maybe you offend and they don't have any issue and they don't have vision loss over time. It's going to be that patient that does progress and does get worse and never knew about this stuff, and is going to sit, 5-10 years from now reading all of this on the internet and saying, like, what if I did this 5 or 10 years ago? Like, what if I made changes? And we don't know what would have happened, better, worse, or otherwise. But I don't want my patients to sitting around saying, like, what if my doctor told me? What if I made these changes? And what if things were different? Maybe I wouldn't have had vision loss today. And like, that's what drives me nuts thinking about it.
Believe me, I understand that. We have a lot of questions popping up, and I have a couple, but one of the things I wanted to get to, and we'll talk about it before we get to the questions, is for those who have intermediate AMD, there's a home monitoring device that can detect a change to wet AMD pretty quick, a lot quicker than waiting to go in for an appointment. Can you talk about that, please?
Yeah, so it's called the ForeSeeHome device, ForeSee Home. It's by a company called Notal Vision. And I'm going to speak just for the United States, but it is approved by Medicare. My patients who are on it and on Medicare pay nothing per month. I think one of them pays like $5 a month because they don't have a supplement. people that are younger and on commercial insurance. I think the most my patient pays out of pocket is like $20 a month. So it's not cost prohibitive by any way, which means there's no reason to not be recommended to do this if you have intermediate AMD. The difference is a lot of doctors just haven't picked up on it yet. It is also new, but they have really good studies that show if you just have standard care in intermediate AMD, that means you've told them about it, you've talked to them about AREDS, you know, you monitor them maybe every 6 months or so, and you tell them to watch their Amsler grid. It's only like 30% of those patients that end up converting to wet that have good vision. And we define good vision in studies in the eye care world as 20/40 or better, which is kind of typical driving cutoff vision across the states. So it's like 34% of patients on just regular monitoring when they converted to wet had better than 20/40 vision. And again, if you remember back, rewind a little bit, the other studies have shown that whatever visual acuity you're diagnosed at with wet conversion, that's about what you're going to stay at. You might have a little bit of an improvement, but it's not just some magic fix either. It slows the progression of it. It will absorb some of the fluid that's in there, but it doesn't reverse the damage that's already been done for it. So this ForeSeeHome device is something that's set up in your home. You don't even need internet. They like attach a little hotspot to it if you need. You really don't have to be technologically savvy for it. There's like an on-off button. And essentially what you do is you're looking in this visor type instrument, and on the inside, there's a line that comes up with a bump in it, and you take a mouse and you click on top of the bump. Like that's the test. And how it checks for conversion to wet is that if you change to wet macular degeneration and these blood vessels are leaking and bleeding inside of the eye, it swells and it changes the structure of the retina. So it sort of bubbles up in certain places and it's less in other places, and our vision gets distorted. So that's why if you looked at the Amsler grid and lines are distorted or wavy or missing or changed, it's because it's either damage to the retina from geographic atrophy, or the bigger concern, especially in a sudden change, is that it's converted to wet macular degeneration. So the way that test works is that if you convert to wet, it ends up being more obvious on that bump than the one that is computer generated. So you accidentally click on a wrong bump that's really created by your retina. And how this works is to end up being covered by insurance, you do have to take it 3 times a week, right? It takes less than 5 minutes per eye to do, so it's not a big commitment. And then it communicates with me all the time that I can see how often you do it, if there's any subtle changes that are happening, and if all of a sudden there's a change that they consider statistically significant, I get an email, a phone call, and a fax about you right away. And they actually follow up in a phone call with me in 24 hours to double check. So it's my job, if there's a change, to call you and say, hey, like there's something different. Why don't you come in and we're gonna check what's going on. And so that's generally how the instrument works. And then comparing to that, the normal monitoring study with 34% were 20/40 or better, patients on a ForeSeeHome device who converted to wet, 81% of them were 20/40 or better caught at the time of conversion to wet. So it was really significant and can really save some people's vision if you do have that intermediate, especially if you're progressing high risk to convert to wet.
And I will put a link, again, we've shared that information in the group several times, but I'll put a link to that again so that anybody with intermediate AMD can ask their eye doctor about it. Okay, good.
And it's free to your eye doctor too, I'll say. So like, dark adaptation, we have to, the practice has to make an investment and purchase the instrument, which is sometimes feasible, sometimes not, especially for tiny practices, that there's tens of thousands of investment to do that. The ForeSeeHome device for the practice is also completely free. The reps come in, they give us the material. We write, like when I find somebody who has intermediate AMD and I recommend it, I just write them a prescription. I can fax it or do it on they have a portal, and then they literally take it from there. They check your insurance, and usually 48, 72 hours later, they call you. So they'll pre-authorize your insurance. You'll know what you have to pay out of pocket if there's a copay, and they help you with setup, etc. So for the doctor, it's also super easy that there's not a lot of excuses on the doctor's part to not get on board with it.
Yeah. But here's a question related to this. If somebody has wet AMD, can the ForeSeeHome detect a bleed or a leak before the next injection?
Nope. So it is for intermediate and to catch conversion to wet AMD.
Okay.
Now on that front, what is coming, because there's just another study that has gotten a step further to FDA approval, is likely by the end of this year for those with wet macular degeneration are going to have a home OCT device, which is really cool. And they're trying to get it approved through insurances. So there's just stuff to jump through yet, but the studies have really shown that patients are very easily able to do it on themselves at home. They're getting good results. It's sending it to the doctor. And so at least initially when it launches, that will only be for patients with wet. And it'll be for exactly that, to watch in between injections where some people leak a little bit before their next scheduled injection. So then they can call them and have them come in sooner. Others, it will help them to do the injection and extend the visits in between having to do injections, because maybe you don't leak as soon as they think. So it's going to help personalize care of how often you do the injections, and it will help them, the ophthalmologist, decide if one drug maybe is working better for you. Sometimes we have to switch those, either if it's insurance or some people just respond to one drug better than another. So it'll help, I think, them catch that sooner and make changes sooner rather than just like wait and see, if you will. So that is coming for wet AMD, which we're also excited about.
Yeah. Let's talk about the stages a little bit more. This is Jones, I think, question. She says she understands that AMD always starts with dry. Does that mean that if I have wet AMD, I also have dry AMD?
Yeah, to a point. So once you convert to wet, we sort of just change. There's like diagnoses code that we use, to be honest, to bill insurances and such. So once you convert to wet, we sort of just say that you have wet macular degeneration because we are watching that. But you can have wet macular degeneration and geographic atrophy, which is dry and wet at the same time. So some of it is just semantics and just picking how we describe it. But it definitely can happen at the same time.
But it's only the advanced dry that you can have.
Right.
With, yes. Okay.
Correct.
Okay, good. Okay, let's see. Yikes. Let's see. Jody had asked, she only has mild AMD in one eye, mild cataracts. She can't exercise because of a health problem. Since she's really not a good candidate for an AREDS 2 supplement because it's mild AMD, what can she do for prevention? And I think with anybody, my understanding is everybody's so different. The optimal would be, doing your exercise and eating all your leafy greens and, just doing everything on a list, but that's not feasible for everybody. So basically you do the best that you can in each of the categories. You keep your blood pressure, your cholesterol, your BMI in a normal range, right? Overall healthy. Eat the best diet that you can. What else?
Yeah, and that would be somebody, the early macular degeneration, that would be somebody that I would have the conversation of, AREDS 2 hasn't been proven to prevent early AMD converting to late, but, you already have some factors working against you that, depending on, the rest of your health and going over medications, et cetera, and barring no concerns with that, maybe it's worth it for you to do that. Or in the short term, maybe even if it's early, most people will probably say like, I'll see you in a year and see you once a year. But maybe with that, it's like, well, maybe we'll see every 6 months and see like how fast or if it's progressing. And then that would just give me a better answer too. So I think one thing that optometrists get annoyed about me when I lecture is I don't have like a standard cookie cutter, like this is how we manage macular degeneration. Where I think so many people just want that handed to them on a beautiful plate, and everybody's just so different. And if AREDS 2 as a total formula really isn't going to be something that does match with their health, the rest of their health. You know, we could talk about just doing carotenoids, you know, lutein, zeaxanthin, there's talk about certainly mesozeaxanthin, and that all comes from not structural anatomic studies of macular degeneration, but it comes from macular functional studies showing that even normal retinas and early macular degeneration have improved visual function with the carotenoid supplementation. So to this point, it hasn't been shown to change the progression with regards to anatomy of it alone, but it also hasn't really been studied extensively. But I'm sort of in the field of maintaining your vision. So obviously I have to, in order to do that, I have to manage your eye health conditions. But then it's a matter of how can we optimize your vision of whatever you do have. And sometimes that is talking about carotenoids, lutein, and maybe not the full AREDS formula, depending.
So in other words, we talk so much about visual acuity, but that's not the only aspect of our vision. There's contrast sensitivity, dark adaptation, I'm blocking.
There's motion sensitivity, you're right. It's like blocking out certain things in your periphery. Mm-hmm. There's so much to our vision, and practically just in a clinical setting, we just don't have the ability to measure all those different factors to really assess full vision. The easiest way is visual acuity, but you can have even like really toward the advanced side of intermediate macular degeneration that I'm super concerned you might convert to wet like any day. And those patients still have 20/20 vision, some of them. So visual acuity is one of the last things really to change in somebody who has macular degeneration. What does change is what you alluded to, is like contrast sensitivity. So not having the best lighting or not having perfect like black on white print, smaller print, or, you know, newspapers, it's sort of a gray background with not a super dark print on the page anymore. And that is harder for people first. So you might say like, oh, it's really hard for me to read the newspaper when you come in. But we're checking your glasses prescription and your reading vision with these pristine white reading cards with perfect black letters on them. And we always get better results than what you physically experience at home. And that's the stuff that we try to manage with, you know, the lutein, carotenoid supplementation, et cetera, that hopefully we can just improve your visual function overall while we're managing the disease.
All right, let's talk about Drusen. Let's see. Julie asked, just read that one can have Drusen without it being macular degeneration. Is that correct? And what's the difference between soft and hard Drusen? And is it relatively easy to see on an OCT?
So yes, it's true. You can have like normal age-related Drusen without having true macular degeneration. And the difference between those two, it's still the exact same concept that waste product is not getting pushed out of the retina. But with like the normal, just age-related Drusen that come with age, it's just like a localized issue in that specific location of the Drusen that you do have. It's not the disease of macular degeneration where the entire underneath of the macula is awash with this deposition, and it really is a disease process. The way I can tell that apart is with dark adaptation. So with the studies for that, it was shown to be 92% specific, sensitive, and accurate for macular degeneration, which means if you're normal on that test, I'm 92% certain that you don't have macular degeneration, even if you do have some Drusen. So there is a way to tell the difference. Before dark adaptation was around, or for the practices that still don't have it, it was more of a watch and wait situation, which is, I think, why some doctors really have a hard time having the conversation with patients about macular degeneration. Because if you're not certain about this diagnosis, that is scary to the patient. They know, at least generally, it can cause significant vision loss. And you don't want to be the one to tell them they have something when maybe they don't, that they just decide to not say anything and just watch it, which is not a good decision. But really, I think that's what happens. And having the dark adaptation, like, oh, I have some Drusen, let's see if this is something to worry about or not. Being able to have that value, and then hopefully they have a normal dark adaptation. But even if you have Drusen, I'll do that, repeat the dark adaptation test over time. So now I'm not only interested in, are you normal for the test, but are you progressing compared to you in the past? So like watching like person and person over time rather than just looking at statistics. So it also helps as I follow them over, you know, months, years, etc., about making those decisions or changing game plans down the road. So yes, you can have drusen without macular degeneration. The soft versus hard drusen, you can tell on the OCT a little bit, but honestly, it's much easier to tell just looking at them. So the difference is, and soft drusen, we'll say, is more at risk to convert to wet than hard drusen is. And all of that is built up of this waste products and this cholesterol deposition under the retina. But the theory is when it's hard drusen, all that cholesterol is really tight and like packed into a ball, super hard, like a little rock. And because they're really hard and sitting on top of it, the blood vessels have a harder time actually growing through them and causing the wet and leakage into the retina. Whereas the soft drusen come as that cholesterol and the waste builds, it sort of just spreads out, and it does, like it actually looks like fluffy and kind of softish as we look at it. And because it physically is softer that way, the blood vessels have an easier time pushing through and converting to wet macular degeneration. So the hard versus soft drusen definitely matters. The size of your drusen definitely matters. So there are, there's based on measurements, there's small, medium, and large drusen. And the other really hard part about diagnosing intermediate AMD is that this goes back to the AREDS study. So this judging of drusen comes from the AREDS study itself, that to categorize if you're an intermediate AMD, all you need to have is one large drusen in one eye. That you were automatically put in the intermediate AMD category. So the size of your drusen matters. The hard versus soft drusen matters because all this stuff builds up as to what stage you're in, and also to how likely you are to progress in our mind in our assessment with things too. So it does matter. And that's why intermediate AMD is really underdiagnosed, because a lot of doctors go by feeling like, oh, this retina looks pretty bad. Like you likely have intermediate AMD, or you can have a lot of like tiny drusen, and per AREDS, that's early AMD. It is not intermediate. And it can be a starry appearance through your whole retina, but as long as they're teeny tiny, it's not intermediate. Versus, you know, the next person in your room whose retina overall looks great, except for one drusen that happens to be a big one, and that person technically is an intermediate. But the look at them just to see a picture, if you don't know that science, you could judge it very wrong. So that's like just another consideration for me about where the AREDS lies, because while that study showed us what intermediate AMD is, there's so many doctors not understanding that and practicing that way that I think we're missing people who should be on AREDS that aren't because of that too.
And you can have drusen outside the macula, right?
Mm-hmm. Yep. So you can have some like what we call along the arcades, which is along the blood vessels on the inside of the eye, or you can have really peripheral drusen way out to the side. Those really aren't associated with macular degeneration at all, because that really affects the macula, which is the center part of your vision. But that could be like quite a obvious appearance too out in the periphery of your eyes as well.
Is it that okay, so it's not, is it or isn't it, I'll say it that way, a case where you could have drusen outside your macula or on the outside of your macula and it moves? Does it migrate? It can.
It depends on the purpose. It depends on the person. So typically it doesn't migrate, but it can be present in addition to like central macular drusen as well. And they sort of will form on their own. It's not that they like move or coalesce to a different location. Yeah. But you can have them in all different locations within the retina.
Can you expect that when you start to have drusen, that as time goes on and you have dry macular degeneration, will you always get more drusen?
Nope. So okay. Some people stay the same even in early AMD, like for decades. I mean, truly, I have some patients that have been diagnosed with drusen before I was in practice, and just like looking back 20 years ago, it's almost the same. So having macular degeneration, why it's important for us as doctors to take it very seriously. And it is scary for a patient or for you to hear that you have this disease. As long as it's caught early and we're aware of it, it's pretty well, managed over time. Because the other thing that I can do is, because while some patients keep their great vision forever and never have vision loss, no matter what we do, the exercise and diet and not smoking and the AREDS, there are some people that still progress anyway, which breaks my heart. But just at this point, science hasn't figured out how to stop it from happening to everyone. But even with those that do unfortunately lose vision under my watch over time, it gives me time and them time to understand what's happening, what different adaptations are available for them. I'll recommend them to see a low vision doctor when their vision starts to bother them. So that's not waiting until they're like 2200 or worse and legally blind. It's, maybe you're 2030, but you're still working a desk job and you can't see your computer anymore. It's like, well, that's a reason to go talk to somebody who knows about what is available with computers, monitors, settings, et cetera, et cetera. I would love you to go see somebody in that specialty because they'll be able to help you and we can sort of walk you down that road of losing vision, as opposed to these poor patients who never even knew they had macular degeneration and develop wet and now have terrible vision all of a sudden and their whole world changes in an instant. And you don't really get a whole lot of vision back. And now all of a sudden you have to adapt from having like reasonable vision to terrible vision. And that is just so much harder over time for people.
Yeah. About Drusen again, it's made of the same stuff as cholesterol. So is there a relationship between having high cholesterol and having Drusen?
They haven't shown that yet. So it is the same, but you can get, cholesterol buildup with normal cholesterol, like in your carotid arteries or around the arteries in your heart, etc. So it probably is related a little bit, but it's not a direct correlation. There even was a time that they studied a really high statin for patients with macular degeneration and to reverse the Drusen, and they sort of had some luck with it, but it caused a lot of side effects to it. And again, like looking at the risk benefit, it's kind of installed in research. But there is definitely theories around there floating around, which is just another reason to watch your cholesterol and keep it as well controlled as you can.
Okay, let's see. I don't want to miss anybody's question. Margaret asks if you have geographic atrophy, should you be taking an AREDS 2 supplement?
At some point, it just doesn't help anymore. So if you have, geographic atrophy in both eyes that really has obliterated your vision and really has you down with a lot of geographic atrophy, at some point, it just doesn't help any longer. To me, if you have good usable vision, like even in one eye, and usable vision is defined very differently from person to person, depends what you do, how you're doing it, like what your living situation is, etc. So I don't have a cutoff for it. But as long as you have usable vision in at least one eye, I will keep you on the AREDS formula as long as you're tolerating it well and you're doing good.
Okay. Sherry says, I have GA in one eye, wet in the other. My RS retinal specialist says my eye with GA could go wet. I wonder why the ForeSeeHome wouldn't help for someone with GA. He said to let him know if I see any changes in my eye with GA and alert him right away.
So one of the needs in the ForeSeeHome device is that you have to have better than 20/60 vision for the test to work accurately. So some people do have geographic atrophy that's not right in the center of their vision. Maybe it's off to the side a little bit, that you might be a candidate for it. But if you don't have 20/60 vision or better, the instrument's just not going to pick up on the changes enough, and it's not going to be helpful for us.
Do you know if the device ForeSeeHome is available in Canada?
I don't think it is, because I had this question last time and I reached out to my rep, is that they're in full gear to get the home OCT out to market in America, and that Canada is definitely on their list, but they're like all gears go for getting this home OCT approved first. So hopefully that comes to market, maybe later this year, and then they are definitely planning on expanding to other countries. So it's coming, but not quite yet.
Jody asked whether she should get a second opinion, and there's always conversation about second opinions.
I mean, listen, with my patients, so this is how I get around some optometrists being concerned, with that. They're like, I'm going to tell you to have early AMD and this is what we should do, lifestyle changes, ABC. You get nervous, you go for a second opinion to the retina specialist or so, and they're like, oh, you're fine. Like, it's just early. Like, don't worry about it. We're not going to recommend AREDS. Like, see you next year. Most retina specialists, it's definitely a generalization, but most of them follow very specifically the AREDS 2 recommendations, that they will not say to do it if you have it early. And for whatever reason that is, again, it's neither right nor wrong, but that's just sort of my impression overall. But how I preface it with patients is cool. You can always get a second opinion. That is more than your right to do that. And that's great. I'm happy to send my records, whatever you need to help you out with it. But I will tell you that I am much more aggressive than most of my colleagues in diagnosing and managing this, because if you have vision loss from this disease, I can't get it back for you. There are things that are shown to slow it down and prevent it, but I would rather you know this information up front, know what's out there. I'm like, these are my best recommendations for you. You're more than welcome to go somewhere else, but I'm telling you, somebody else may just brush it off and it's not a big deal, but it's a big deal to me because of that. But, so I sort of preface it that way, because there are, of course, varying opinions out there. I don't think getting a second opinion ever hurts. But I would say to find someone who really specializes in macular degeneration, and that typically are going to be doctors who carry that Maculogics instrument, who are already in the know about ForeSeeHome, because they're just up to date with all of the new stuff that is out on the market, that you're not going to get old information from AREDS 1 and AREDS 2, and that we're thinking about new information coming out now. So if you really want a serious second opinion and not just go to another doctor down the street, that's what I would say, is find somebody, if it's possible, within your area and your zip code, and see what they have to say.
Most optometrists, I would say, are perfectly capable of diagnosing dry AMD and monitoring it, right?
Mm-hmm. Yeah, and I would say you can double check them on their website, but if they're like a reputable private practice, not necessarily commercial eye care settings, some states don't allow that, but many do, where their business is to prescribe glasses, do a quick health check, and and move on. So if you find a private practice, you can definitely find their website. Typically they'll have listed like what they do, what kind of conditions they manage, etc. And often some of them have like listed what instruments they do have. So like maybe the dark adaptation is on their website, etc. So you can do a little bit of digging before you just go to somebody else for the sake of going to somebody else. Like, make that second opinion worthwhile for you.
Excellent. Yeah. I think I have, there's one more question. This person, her name is Piggy Wiggle. I think that's a pseudonym. Yeah. Anyway, I have intermediate dry AMD and also a cataract developing in the same eye. I lost the vision in the other eye some time ago. Okay, how can I best protect the remaining eye? I think we've covered all that, but her question is, she's in the UK, there's a long waiting list for cataract surgery. Does a cataract ever reach a point where they can't operate, they can't remove it?
Not really. I mean, in extremely severe cases, which we're mostly talking about third world countries who don't really have access to healthcare. So extremely rare for them to get that bad. That when I talk to my patients about cataracts, like, it's, to me, way low on my list of concern, because cataracts are more a consequence of the aging process than it is a true eye disease. And if you live long enough, everyone gets cataracts. So like, congrats.
Yeah, there you go.
And so it, generally speaking, healthy people in a country that you're regularly monitored for medical conditions, we just decide about when to do cataract surgery based on it's certain, like my criteria is I need you to be legal for driving. All right. So typically I need you to be 20/40 or better, or I start to twist your arm that you need to go and have surgery. And then aside from that, at least in America, it's approved for anybody who has symptoms of cataracts. And that goes from maybe it's blurry on the eye chart, to the glare that has been caused by the cataracts is just disabling. So I have some, for example, like truck drivers, and they drive at night all the time, and the glare just really is inhibiting their occupation. That they might be 20/20 or just a little bit less on the eye chart, but it's bothering them so much. I'm like, well, I think it's reasonable to talk about it. I have other patients who, you know, their vision's not great, but they're doing okay. Maybe they're retired. They don't drive at night anymore. The glare doesn't bother them. And it's like, cool. You know, whether we do the cataract surgery like 2 years before or 5-10 years after, the result is the same, assuming the rest of the inside of the eye is healthy, the retina is healthy, etc. You remove the cataract, you put the implant in place, and it cures the problem of the cataract. The only time I have consideration of cataract surgery with macular degeneration is with active wet macular degeneration, in which case I'll make sure that the retina specialist is on board with it too before I just say go and have cataract surgery. The dry macular degeneration, really nothing has been proven that the cataract surgery makes that worse. And in fact, giving people better contrast by removing the cataract improves your vision. Even if you have a lot of damage from macular degeneration that you don't see well on the vision chart, it's still worth doing cataract surgery because things in the periphery will just be brighter and clearer and easier to see. Because the general experience of cataracts is sort of like having that fog on your windshield build up when you want to put the defroster on, and it just gets denser and denser and denser, and at some point you can't see through it. And that really changes the contrast. You know, like glare is terrible, lights are coming through that hazy windshield. And so it's reasonable to talk about it anytime it is affecting your vision. The wet AMD, especially if it's active, there's some studies that show it might make it a little worse. So I just want to make sure that the retina specialist feels like they are stable enough to do the surgery. So I just make sure that they're on board with it.
Yeah. Back to about the ForeSeeHome again. Joan said, as Barbara asked, can a ForeSeeHome detect a bleed? Joan, the ForeSeeHome would be for somebody with intermediate AMD, and it would detect a bleed. That's the purpose. Yeah.
Correct. So the way it's not detecting the bleed by anatomy, like by the OCT and like us looking at your eye. It detects the bleed by all of a sudden, we call it metamorphopsia, where your vision might be okay like 20/20, but things are just like crooked or wavy or missing because instead of the retina being a nice flat smooth surface, it gets some bleeding underneath and it like pops up where it bubbles in different places, which makes your vision sort of bubble along that exact same line. So that's how it works. And if I get an alert, I'll bring you in and check. So I've had 2 alerts that patients did convert to wet, but I've had another alert that there's a different macular condition called macular pucker or epiretinal membrane. And that patient, his just happened to progress a little bit, and it too can cause metamorphopsia and waviness. So thankfully for him, he didn't convert to wet. So in that case, I talked to the company. I said, this is what happened. His epiretinal membrane changed. So we're going to reset it. And that is his new baseline. And now we're watching changes from that point. So interestingly, it does catch other things, but obviously mainly meant for catching that early bleed or leakage into wet.
Yeah. And Jolene asks, can having ocular migraines be related to being diagnosed with dry AMD?
I don't think so. They're 2 separate conditions. I have patients with ocular migraines very commonly. A lot of them are younger. I haven't seen it cause Drusen or any changes over time, so I don't think they're related.
Okay, wow. I've gone over the list a couple times. I think I've got everybody who sent me something in chat. It's a little after 9. Should I? Whoops! I just had to say that, right? Oh boy. And we get to not a small topic, but what about family history?
It's not a small topic. So family history is important. It helps me with assessing all of the risks that you have between what your retina looks like, what your dark adaptation is, what your diet is like, what your general overall health is like. It's another piece to the puzzle I use. So macular degeneration is a complicated genetic disease. As in, there's some retina diseases that you inherit a gene from mom or dad and you automatically have this retina disease. Macular degeneration is not like that. We know there's at least 26 genes involved in macular degeneration, and some of the genes that you inherit are good and protective against it. And some genes you inherit make you more likely to develop it. And all of those things work in concert together. So it's not easy to predict just going down families unless it's just so strongly, like my mom and my dad have it, my brother and my cousin and my uncle. Like maybe I'd be like, all right, well, maybe you're almost destined for this, that we're going to watch it super close. But generally, it's a little red flag that I get going up to watch, but it doesn't mean that that is going to happen to you.
And I think that it's 15%. It's only, I want to say only.
Mm-hmm.
When you have a family history, it seems like that's got to be the cause. But AMD, as you said, is very complicated, and only 15% of those with AMD have a family history.
Okay.
Does that sound right?
A statistic I didn't even know. No, I don't know. I didn't hear that statistic. So that's interesting though.
Yeah. And having a family history doesn't mean you're going to get AMD either.
Correct.
However,
so it can definitely happen. Zero family history, and you can scoot by no issues your whole life with having a strong family history. So it's a risk factor, but it's not a guarantee.
Right. And if for those who have AMD and who have children, I highly recommend that they talk to the kids now. And of course, a lot of people say, I do talk to my kids, they just don't listen. Anything that's recommended for those who have AMD is good for those who don't, except for the AREDS supplements. They're not designed to prevent AMD. But diet,
so I really don't put anybody on AREDS to prevent it in the first place, because that really just hasn't been proven at all. But yeah, all those other things, listen, with healthy diet, exercise, like don't smoke, keep your body healthy, like those are not things to educate patients on that are going to cause any harm whatsoever. It's only going to help your eyes and the rest of your body to be healthy. And sometimes you just need that one piece of like, oh yeah, this does run in my family. Maybe I should take that extra like leap and quit smoking, or whatever the case is. My biggest recommendation to anybody, like just anybody who has eyeballs, is to just have your regular eye exam every year. You'll be amazed what eye doctors can catch, even if you have perfect vision. I mean, you can have advanced intermediate macular degeneration and have 20/20 vision. You can have advanced glaucoma and have 20/20 vision. And it's those patients that maybe just skip their eye exam for decades sometimes, that they come in and they have all this damage. And I'm like, I wish I could have helped you like 10 years before this, because now I can stop it from getting worse, but I can't get it back, you know? And there's so many things that we can catch far before it affects your vision, that if you just have like your routine eye exams, that stuff should hopefully be caught early, that you can have these conversations and keep up with it, and change things along the road as it progresses, if it does.
Well, that sounds like a good place to close it for tonight. I do want to read you. I like this. Barbara says, Dr. Legge, you are the bee's knees. Thank you for giving us your time and for all the research
you're so welcome.
you do. And Jana says, thank you, Amanda and Linda. And Sherry says, this information is gold. You bet it is. Very clear and extremely helpful. Thank you. Thanks to Amanda and Linda. And then we've got some more thank you, thank you, thank yous. And I certainly thank you. Are there any last quick questions? Well, if you do have them after the session, you can, where can you catch this again? Well, tomorrow morning sometime, I will put this on YouTube. I've started to put all the sessions on YouTube, because for one thing, I can see if people are watching them. I'd like to believe, and they are. So it will be on YouTube, and when it is, I will put a link on the group. And I will also include links to the name of the dark adaptation machine and the site where you could find a doctor who has it, and the ForeSeeHome, and more information about the home OCT.
Yep, and I'm pretty active on your Facebook group, so if anything does come up, I know different administrators have tagged me in things, which is helpful if it's not on my radar, etc. That it's just a big passion of mine, because I think that there's so many things we as eye doctors can do better to preserve vision. And I've been lecturing to eye doctors about this for almost 10 years now, and there's movement, don't get me wrong, there's movement, and there's a lot being uptaken in the community. But I would love this little grassroots movement from the patient standpoint too, to like kick their doctors in the butt a little bit and get moving along.
That's right. And Alice says, what is the Facebook group? Well, it's called Our Macular Degeneration Journey. Yeah, that's it. Our Macular Degeneration Journey. I assume you were invited here by a member. So if that's not clear, you can talk to them about it. And I think with that, we'll say good night. And thank you so much for taking time out of your busy day. Once again, thank you.
Happy to do so. I'll see you guys later. Have a great night.
Bye, everybody. Bye-bye.